So it's my pleasure to introduce Dr. Bernie Eigl. Dr. Eigl is a medical oncologist at the BC Cancer Agency. He graduated from McMaster University and completed his oncology training and genitourinary fellowship at the BC Cancer Agency before moving to Calgary, where he served as the head of the genitourinary tumor research group, medical director of the clinical trials unit, and director of the Alberta Clinical Cancer Research Unit. Currently, he is the provincial director of the systemic therapy clinical trials, and Dr. Eigl works to increase the impact and activity of clinical trials for cancer patients in BC. Dr. Eigl, we are so grateful for your commitment to BCC, and thank you so much for being here today.
Thanks very much for the introduction, and thank you to Bladder Cancer for organizing this and for everything you do, really. It's, I think back to the early days when we had your brochures in our clinics and we were really pushing them at our patients. And now I just had a consultation with a patient by phone from somewhere up north about a week ago with muscle invasive bladder cancer. And they had said, we had the diagnosis, we didn't know what to do, but we got in touch with Bladder Cancer Canada, and now we know exactly what is ahead of us. And they already knew before I talked to them about their options of what they were going to do, surgery-wise, chemo-wise, and I really didn't have to be there. So it's really great. I'm very grateful. It's hard to come after the amazing speakers that have already spoken, but I'll do my best. And really speaking now in a different landscape, muscle invasive bladder cancer. So now we've moved from the the superficial, if you like, the non-muscle invasive disease, to something that becomes more serious, and so interventions may have to become more aggressive as well. And it's an area that is just evolving so very rapidly. These are my disclosures. I should have said that before. And really just want to start it with the take-home messages. So when a patient comes into my clinic with muscle invasive cancer, it's much more high-risk disease. This is now potentially a life-threatening disease, but the goal is cure, and this is still a curable disease. The current mainstay of this approach is local regional therapy. So cystectomy, we've talked about. Trimodality therapy is also an option. So using a combination of radiation and radiosensitizing chemotherapy to try to maintain the bladder and still come hopefully approach the same cure rates is an option. Systemic therapies, which I'll talk about, have really improved outcomes and continue to evolve to provide amazing improvements in survival and incremental steps. And as I mentioned, the paradigm is changing so rapidly that if I came and spoke to you a few months from now, I might be talking about different standard treatments than I am today. But first, I really want to go and take a little step to the side to metastatic urothelial cancer or metastatic bladder cancer. Historically, this has been an abysmal diagnosis, and things really have changed in the last few years. So really, for coming on 50 years now, the prognosis, if you had metastatic bladder cancer, so bladder cancer that spread away from the bladder to other parts of your body, this was considered not a curable disease. The median survival for somebody who came into clinic with that diagnosis, even with the best treatments that we've had for the last going on 50 years, was about 12 to 15 months. And 5-year survival rates were very low in the single-digit percentages. And the standard of treatment was platinum-based chemotherapy, and that is not easy treatment with quite a lot of toxicities, which some of you probably can attest to, and we can talk about more. But things have really changed, and we've heard about the immune system and its role in bladder cancer. The immune system is really an incredible thing. When you think about it, our immune system can eradicate COVID, can eradicate pneumonias, can eradicate all sorts of things. Our immune system can eradicate cancer. And it is constantly working in those of us who don't have cancer, constantly working, looking for cells that have gone bad and could turn into cancers and get rid of them before they become cancers. So it's a very powerful thing if we can turn it on. Here I've mentioned the goal of immunotherapy in the advanced setting of disease is really to prime a patient's own immune system to recognize and eradicate the cancer. And there are other new therapies that have been developed. I'm not going through all of them right now. You heard about FGFR targeted therapies. We have those in our clinic now. We have other targeted therapies, but another one is antibody drug conjugates, which is in the way I describe it sometimes is like a homing missile. So just realized I have to stand in this place to be seen. Antibody conjugates are really drugs that have been designed to be antibodies that have been engineered, just like the antibodies our own immune system makes, that stick to targets. And they, in this case, they would stick to bladder cancer cells. And if you put this drug, you conjugate it onto the antibody, you basically make this a homing missile. So the antibody sticks to the cancer, carries a poison with it, and that poison goes into the cancer and kills the cancer cell, if that makes sense. And these treatments have had an amazing effect in bladder cancer. Over time, we've been combining these treatments to get even better effect. And so I know I'm supposed to be talking to you about muscle invasive bladder cancer, but you'll understand why I'm on this track in a few minutes. In 2023, there was a study done which looked at this combination. So patients with metastatic bladder cancer, 886 patients, who would normally undergo standard treatment with chemotherapy that I've mentioned, and you've heard the words gemcitabine and cisplatin bandied about, and that is the standard treatment that we use for advanced bladder cancer. Or they would receive this combination of a drug called enfortumab vedotin, which is one of these antibody drug conjugates, plus pembrolizumab, which is an immunotherapy. And so really is trying to kill that cancer cell directly with the homing missile, if you like, and then get the immune system to recognize the pieces and wipe out any other cancer that might be lingering around. And that study was looking at patients to see how they responded to the treatment, progression-free survival, so how long they lived without progression, and overall survival, so how many patients are alive at the end of the time frame. And so I live in the world of curves like this, overall survival curves, which everybody in the two groups, 100% of patients are alive at time zero, and as time goes on, and unfortunately, patients die from cancer or other causes, and so the curves will always go down. And you can see here, there's a quite impressive separation of these curves early on, and this really is a huge breakthrough in any cancer treatment, in bladder cancer especially. You can see here a doubling of survival from 15.9 months with chemotherapy to 33.8 months with this new treatment, enfortumab vedotin and pembrolizumab. You can see on this plot really is just showing for patients, all patient subgroups. So they looked at, might be a bit hard to see here, patients under 65, over 65, whether they were white or not, where they lived. It really doesn't matter whether you're male or female. All groups benefited from this treatment. When those dots are on the left side of the dotted line, that means you did better with the new treatment. And so outcomes for everybody were better with that treatment. Another really important key is when in the old days of chemotherapy worked, it shrank the cancer, but it didn't work for very long, and patients would progress. And unfortunately, at that point, again, that the treatment options were limited in these days. And you can see on the top right, the numbers you see, their median duration of response. So for patients who had a response, their cancer shrunk with the treatment. How long before the cancer started growing again? With chemotherapy was 7 months. And that's what we would see in clinic back in the old days, in quotation marks, of chemotherapy. With this new combination EVP, 23.3 months. And what we can also see is that 67%, so 2/3 of patients had a response where their tumor shrank more than 30%. And so these patients had a good duration of response. You can see it 24 months, 50% of them, 49.4% of them still had a response of their cancer that was maintained compared to 24% with chemotherapy. And for those patients, the 30% of patients had all their measurable disease disappear. So when we did scans, we didn't see any cancer anymore. At 2 years out, 75% of those patients still did not have any cancer anymore. And so these are really groundbreaking changes in this incurable disease. And I put incurable in quotation marks now because the textbooks for metastatic bladder cancer will say this is an incurable disease. I had breakfast last week with a gentleman that I put onto one of these clinical trials 10 years ago, and he's free of disease, he's cured. And more now we're seeing patients who are cured of this disease. And that's why I love what I do. So back to, EV Pembro, just so you remember, that's the combination that really has been the breakthrough and we use in advanced disease. And as Dr. Black alluded to, we do clinical trials in the advanced setting because we want to offer patients the best treatments that we can upfront. And when new things come along, we test them in the advanced setting first, but then they move earlier and earlier into the disease setting. And so now muscle invasive bladder cancer is an earlier setting. You've seen something like this before. I'll just go through the numbers, and it is frustrating. Bladder cancer is the #5 cancer in Canada, and we don't talk about it. And it really is an ignored child in the family of cancers, I guess. Patients present with muscle invasive bladder cancer. So this T2 lesion that you see there, unlike what Dr. Black was talking about, we're now past this laminar propria and into the layers of muscle that make up the wall of the bladder or deeper, T3 being all the way through. That's important because that's all the blood vessels and lymph vessels and other vessels that can carry cancer cells around the body are there. So the cancer can figure out how to get into that area. It can potentially get into one of those vessels, float around the body, and just like a seed from the weed in your garden can land in fertile soil somewhere else, it can start growing, and that's the metastasis that develops and, again, is incurable in quotation marks. And so the prognosis is worse. 25% of patients present with muscle invasive bladder cancer, and a proportion of them, as Dr. Black alluded to, can progress to muscle invasive bladder cancer from non-muscle invasive disease. And the survival rate on average is around 30 to 50% at 5 years for this. So the prognosis is something, although we say it's curable disease, it's something we take very seriously, and we want to maximize the chance of cure and survival. So because there's this high risk of metastatic spread, we can't manage it by local means alone anymore. You can't just do intravesical treatments. You need to do more involved treatment. So it's coordinated care. Urologists, medical oncologists, radiation oncologists, we all work together to say, what do we need to do to maximize the chance of cure for patients with muscle invasive disease? And the standard of care today would be to provide chemotherapy, cisplatin-based neoadjuvant chemotherapy. So neoadjuvant means you're giving it before the definitive local treatment of surgery or radiation. And that's our standard of care. And I will focus mainly on cystectomy going forward because a lot of the clinical trials that I'll talk about were looking at cystectomy. But again, trimodality therapy is also a reasonable option for the right patient. So as I said, the current standard of care, if we walk from the left side here, somebody's identified to have muscle invasive bladder cancer. If they're eligible for cisplatin chemo, and again, cisplatin is a hard chemotherapy. It can affect your nerves and give you what's called peripheral neuropathy, so numbness and tingling in the hands and feet. So if you already have that, we don't tend to use it. It can affect the kidneys. It can cause hearing loss through affecting the nerves to your ears. And so if you have some of the factors already existing that we don't want to make worse, then we would not give you cisplatin. But if you're eligible for cisplatin-based chemotherapy, that would be our standard treatment first, and then the cystectomy. And I'll talk about the other treatments in a little while. Focusing in on the cisplatin-based treatments, this is, again, a really busy slide. I don't need to belabor it, but this was actually work that was done in Canada by our colleague, Dr. Winquist, looking at all the studies that have been done around the world, looking at chemotherapy given before cystectomy or definitive local therapy. And at the end of the day, that little diamond at the bottom is on the left side of that dotted curve. And remember, if it's on the left, it's better than the standard, which would be no chemotherapy. And so that showed that giving chemotherapy is better if you add it to the surgery. So the cure rates go up. And in absolute terms, it's a incremental benefit. So let's say your chance of cure is 50-50 with surgery alone. The improvement might be 5 to 6.5. Now with newer treatments, maybe 8 to 10%. But let's say we make it 58% versus 42%, your chance of cure. So it's improving the chance of cure slightly, but as an oncologist, if I see an 8% improvement in cure, that means I need to treat about 10 patients, 12 patients in order to cure one. So for me, that's a reasonable number. Obviously, we want to do better. And that's where we have been for 50 years now in terms of our treatment options for bladder cancer. The chemotherapy options you might hear and that are standards in Canada would be gemcitabine and cisplatin. I mentioned it's a 3-weekly treatment, and you would get an intravenous treatment of both drugs on the first day, and then just the gemcitabine drug usually on day 8, so a week later, and then you don't come in the next week, and then you start all over again, 3 weekly cycles, and those repeat 4 times. So 3 times 4 weeks would be 12 weeks of treatment, and then you go for your cystectomy after that. The other therapy that's now available is called dose-dense MVAC. So, and interestingly, MVAC is 4 drugs: methotrexate, vinblastine, adriamycin, cisplatin. These are probably 4 of the most toxic chemotherapy drugs that we have, but they're also very effective in bladder cancer. And now with the medications we have for anti-nausea and supporting your bone marrow through treatments, we can actually give these treatments quite safely and relatively well tolerated. So if there are patients who are fit for it, dose-dense MVAC is an option as well, and it's nice in the sense that it's given every 2 weeks, and usually we give it for 4 cycles. So you're looking at only 8 weeks of treatment before you can go on for your definitive treatment. So what about patients? So patients will have their chemotherapy, then their cystectomy. What comes next? And really what we look at there is, and the good thing about cystectomy is it gives us a tool to look at what is the risk of the cancer coming back, because that's always the most important thing, right? It's not the tumor that you have in your bladder, it's the risk of cancer spreading somewhere else in your body that we worry about. And there is something called the pathologic response that we can look at to give us an idea of what is the risk of the cancer coming back. And you've seen on the earlier pictures, PT or T2 is muscle invasive, T3 is through the bladder. It's just a way that we define what the tumors are doing. And so if at the cystectomy, when the surgeon takes out the bladder, it goes off to a pathologist, they look at it all under a microscope to tell us how much cancer is still left behind. You've just had chemo. Did the chemo wipe out all the cancer and there's nothing left behind, which would be called PT0? Or there's a little bit just invasive T1, or is there more disease? It's actually still muscle invasive disease there, or N positive, which means the cancer has spread to the lymph nodes that were taken out in the surgery, which means if there's that much cancer still left behind, it's probably aggressive cancer, more resistant to chemotherapy, more likely to have spread somewhere else. And we want to look at what can we do to, again, improve the chance of cure in this setting. Whereas if you're T0, actually your chance of long-term survival is already very good just with the chemotherapy and the surgery alone. And so that group historically and current standard of treatment would receive observation. But if you still have high-risk disease and there's a large chance of the cancer coming back, we will now offer immunotherapy to try to turn on your immune system to get rid of the cancer. And so the study that showed that immunotherapy works in this setting is a study, all these studies have fancy names, Checkmate 274. Over 700 patients took part in this study. And these were patients who had undergone they had undergone a cystectomy, and they may have undergone chemotherapy beforehand or not, because remember, some people can't have chemotherapy beforehand, and still had a good amount of disease left at their cystectomy. So there's a high risk of the cancer coming back. And those patients were randomized to either receive a placebo, because the standard of care was to just observe, or nivolumab, one of these immunotherapy agents, intravenously every 2 weeks for up to a year. And then they were followed. And what we can see here, again, is one of these survival curves. The green curve is the group that got the immunotherapy, and you can see they did better. The curve is higher than the placebo group in terms of recurrence-free survival, which means at 6 months, 77% of patients who received nivolumab were free of disease recurrence, as opposed to 62% of patients in the observation. And you can see as time goes on, that separation is still there. But you can also see that the difference is not large, and there's still a lot of room for improvement. The other thing that's important to note is patients who are on the top part of the placebo curve, so up there, are patients who are still alive and never needed extra treatment, but we can't identify who's who and who needs the extra treatment and who doesn't, because there are no magic tests to do that yet. Hopefully one day we'll get there. This is the overall survival for patients with, specifically with muscle invasive bladder cancer, who received this immunotherapy, the nivolumab. And again, you can see a fair difference at 36 months. 53% are alive who just received the placebo versus 64%. So about an 11% improvement in survival at 36 months. So this is promising. This is good treatment, and this is our standard of care right now. We can still do better. We still want to do better. And that's what I said, there's still need for improvement. And that brings us to what is really the emerging treatment paradigm for muscle invasive bladder cancer. This is what's new in MIBC. And it's kind of, I don't know if it's not rocket science, but this is what we do in clinical trials a lot, is if we have drug A and drug B and drug C that work in a disease, why not combine them and see if they work better together? And this was really what was done in this setting. So there was a study called Niagara, much easier river than Potomac to say. And the Niagara study was looking at patients with muscle invasive bladder cancer, and they were randomized to receive either the standard treatment, which I've mentioned to you already. At the bottom here is gemcitabine and cisplatin every 3 weeks for 4 cycles. And then they had their cystectomy, and then they were followed with no further treatment because that was a standard of care. Or they received gemcitabine and cisplatin on the top box that you see there, plus durvalumab, which is another one of these checkpoint inhibitor immunotherapies. And after cystectomy, they received durvalumab again for maintenance therapy for up to eight more treatments every 4 weeks. And at the end of the day, what you see here is there is an improvement in survival for this group. And you can see at 24 months, 67.8% versus 59.8% are alive and free of recurrence. And this is obviously a clinically meaningful improvement, a 32% improvement in the risk of the cancer not coming back in that time frame. And when we look at overall survival, so how many people actually alive, the improvement was significant, with an improvement at 24 months of 7%, from 75% to 82%. And so these are, again, these are just numbers, but they are people, and they're people that I see in clinic, and these treatments make a difference, and that's why research like this is important. This is looking at just the toxicity of these treatments. So everything comes with risks and side effects, right? And so this is what's called a tornado plot. So on the left side, you see patients who received, these colors are all kind of funny. Sorry, so on the left side, you see patients who received chemotherapy. On the right side, you see patients who received the chemotherapy plus the immunotherapy. And you can see at the end of the day, there's no huge difference in the side effect profiles of these. And although the numbers are quite large, again, Dr. Black alluded to grade 1 and 2 toxicities are they're a nuisance, but they're not really affecting my day-to-day activities. Grade 3 is now I'm having to do something about it, and grade 4 is life-threatening. So the dark boxes you see are grade 3 and 4 or higher. And so this is something that's really actually quite manageable, and we're giving these treatments routinely. The other important thing is we don't want to give treatments. If you imagine, if we're giving neoadjuvant chemotherapy before the cystectomy, we don't want to give something that's going to be so toxic that you don't end up getting your cystectomy because you're too sick to have your surgery. That would be taking away the really important definitive treatment that gives you the highest chance of cure. And we see when we list all of these side effects here, I don't know if I can use a pointer or not. Essentially, you can see leading to patients not undergoing radical RC, radical cystectomy, the third one from the bottom. is 1.1% in the immunotherapy arm, 6%. What am I saying here? Is a percentage? Yes, 1.1% versus 1.3% in the compared arm. So there's no difference. A very small percentage of patients didn't go on for their surgery. And so that's really important to know. We can give immunotherapy and chemotherapy together, not surprisingly, the guy who does it all the time, without affecting the chance of the risk of your surgery not happening. So that's really important. So what does the future hold? We're now at a point where this is, at the moment, not our standard of care. This is our future standard of care right now. We've seen the survival benefit, but now it has to go forward in front of Health Canada. It's already FDA approved in the States. I think it will be approved in Canada, and we will have this as a standard treatment in the not too distant future. And we want to build on this, and there's lots going on to build on this. The big thing that is coming very soon is what I mentioned to you at the very beginning of this talk, EV Pembro. So we know the huge survival benefit that we saw in patients with metastatic disease. Well, if it works there, why wouldn't it work in patients who have curable disease? And really, can we improve that, the chance of cure even more? And so there are 2 studies that are already completed, and we're waiting for the results of those. And I think that probably will be paradigm shifting. Other approaches with other drug combinations are being evaluated. A study that we're doing in Vancouver right now, who got the Moderna vaccine for their COVID at some point in the past. Okay, so there's a Moderna vaccine for cancer. So there is a study right now looking at patients who have muscle invasive bladder cancer and who have a cystectomy. And if they have high-risk disease, they would come to us, and we would actually enroll them on a study where a Moderna vaccine is made from their cancer, from their surgical specimen. They find the mutations that their cancer specifically has, put that into a Moderna vaccine, and put it back into the patient with immunotherapy to see if we can prime the immune system to really recognize their cancer and get rid of it. Whether that will work or not, we won't know until the study is done, but this is what research is. And I think I will just go to summary. So really, after decades of slow progress, bladder cancer was not a fun field to be an oncologist in for many, many years, but we're seeing really rapid change right now, and it's a very exciting field for me. I have more and more patients in my practice who had incurable disease who are now completely fine and free of disease. And immunotherapy and other new treatments are really becoming the standard in muscle invasive bladder cancer. And you can talk to Dr. Marie-Kirsten Laurent about this a little bit more, but I think we'll reach a day when definitive local therapy is not the only mainstay of treatment. So patients may not have to lose their bladders because our systemic therapies are getting better and better on our ability to identify those people who have complete responses and maybe don't need to have their bladders removed to be cured. Will be identified. We're not there yet, but we're hopefully going to get there.
Thank you. So thank you so much, Dr. Eigl. One question that we often get at BCC is, what is TMT?
So TMT, or trimodality therapy, is really an approach to try to use a bladder sparing approach. So we've mentioned cystectomy is a mainstay of therapy to remove the bladder and any tumor that's there with it. The question is, if I use the analogy sometimes of a weed in your garden. If you're digging the weed out, which is a surgery, can you burn the weed and get rid of all the cancer that's there? And that's maybe not a very good analogy, but at the end of the day, trimodality therapy is a team approach to trying to keep the bladder. And so that would mean urologists are involved in doing their TURBT and making sure the maximum amount of tumor is removed. The radiation oncologist would be treating the bladder area with radiation to try to kill the cancer cells that are there. So that's you're sitting on a table and the radiation machine is moving around, basically putting very strong X-rays onto the bladder tumor to kill the bladder tumor. And a medical oncologist is giving chemotherapy. This time, not the high doses of chemotherapy that are trying to kill cancer everywhere, but rather a low dose of chemotherapy that goes into the bladder cancer cells here and makes them more sensitive to the radiation. So you're really radiosensitizing and making that radiation work better. And that approach of trimodality therapy which there are different ways to do it, but most common would be daily radiation, Monday to Friday for 4 weeks. In the right patient population, there are patients where it's not appropriate to do surgery. There are patients where it's not appropriate to do trimodality therapy, but that intersect of the majority of patients, trimodality therapy has very similar outcomes in terms of cure rates compared to surgery.
Okay, well, if there aren't any other questions, thank you again, Dr. Eigl and Dr. Black, of course, for coming and giving your talks. Very informative and educational. Thank you.